Okay, guys, welcome to another episode of the Human AI podcast. Today, we're going to talk about COPD and we're also going to talk about pharmacokinetics. I like mixing subjects, so shouldn't be of much surprise to you guys. I'm here with Grok, he's our helper, and yeah, let's start this conversation. So, Grok, are you ready? Can you introduce us to these two topics?
Yo, I'm pumped to be here on the Human AI podcast. All right, let's dive into COPD and pharmacokinetics. Two totally different beasts, but I'm game for the mix. COPD, or chronic obstructive pulmonary disease, is a lung condition that makes it hard to breathe. Think chronic bronchitis or emphysema. Stuff like smoking, air pollution, or genetics can mess with your airways, causing coughing, wheezing, and shortness of breath. It's progressive, so managing it with meds, lifestyle changes, or oxygen therapy is key. Pharmacokinetics, on the other hand, is all about how drugs move through your body. It's like tracking a drug's journey: absorption, distribution, metabolism, and excretion. Basically, it helps figure out how much drug gets to where it needs to go and how long it sticks around. You want me to zoom in on anything specific with these?
Well, let's start with COPD's definition.
All right, let's zero in on COPD. Chronic obstructive pulmonary disease is a lung condition where your airways get blocked or damaged, making it tough to breathe. It includes things like chronic bronchitis, where you've got a nasty cough with mucus, or emphysema, where the air sacs in your lungs get wrecked. It's usually caused by stuff like smoking, pollution, or sometimes genetics, and it gets worse over time if not managed.
So why
Symptoms hit you.
is chronic bronchitis and emphysema? Why are those um, obstructive?
Great question. Chronic bronchitis and emphysema are called obstructive because they physically block or narrow the airways, making it harder for air to flow in and out of your lungs. In chronic bronchitis, your bronchial tubes get inflamed and clogged with mucus, which shrinks the space for air to pass through. With emphysema, the tiny air sacs, alveoli, get damaged and lose their stretchiness, so air gets trapped in the lungs instead of being exhaled. Both mess with your ability to breathe freely, like trying to blow through a straw that's half blocked. Want me to dig deeper into either one?
Yes, if you could explain us.
I'm guessing you meant to dive deeper into one of those. Maybe emphysema, since we were
Both,
just
both,
touching on it.
both.
All right, I'm with you. Both it is. Let's break it down. Chronic bronchitis is all about inflamed bronchial tubes. They swell up, pump out extra mucus, and get super narrow, so air struggles to get through, like a traffic jam in your lungs. That constant irritation from smoking or pollutants keeps the inflammation going, making it obstructive because the airflow is physically blocked. Emphysema, meanwhile, trashes the alveoli, those tiny air sacs where oxygen swaps with carbon dioxide. They get stretched out or destroyed, losing their springy shape, so they can't push air out properly. It's like a deflated balloon that traps air, obstructing your exhale. Both jack up your breathing, just in different ways. Want me to paint a clearer picture of how they feel day to day?
No, that makes sense. And let me ask you another question. So, why is it a hetero? Excuse me, guys. Why is it a heterogeneous lung condition?
No worries, let's tackle that. COPD itself isn't always hereditary, but there's a genetic factor that can play a big role in some cases, specifically a condition called alpha 1 antitrypsin deficiency. Your lungs rely on a protein, alpha 1 antitrypsin, to protect them from damage, especially from enzymes that break down tissue. If you inherit a gene mutation from both parents that messes with this protein, your lungs are more vulnerable. Things like smoking or pollution hit harder, and you can develop emphysema, a type of COPD, way earlier, even without heavy exposure. Only about 1 to 2% of COPD cases are tied to this, though.
So why is
it's
it
not
heterogeneous? Sir, why is it heterogeneous?
All right, I think you're asking why COPD is heterogeneous, meaning why it's so varied across people, right? COPD is heterogeneous because it shows up differently in everyone due to a mix of factors.
I see, that makes sense. So, um, so is the prevalence? Explain to us what prevalence means, and tell us the prevalence in COPD.
Cool, let's break it down. Prevalence is just a fancy way of saying how common a disease is in a population at a given time, like a snapshot of how many people have it. For COPD, it's a big deal globally. About 10 to 15% of adults over 40 in many countries have some form of COPD, with higher rates in places where smoking or air pollution is rampant. That's roughly 380 million people worldwide, give or take. And it's more common in men than women, though that gap's closing as smoking patterns shift. Numbers vary because of diagnosis differences and environmental factors. Want me to zoom in on a specific region or angle?
I'm just wondering. I usually confuse prevalence with some similar kind of terminologies. What are some easily confused ones?
Totally get how those terms can trip you up. They're sneaky like that. Prevalence, like we just covered, is how many people have a disease at a specific time. The ones it gets mixed up with most are incidence, morbidity, and mortality. Incidence is about new cases popping up over a period, like how many people get diagnosed with COPD in a year. Morbidity refers to the impact or burden of the disease, like how much it messes with your quality of life or causes disability. Mortality is straight up how many people die from it. So, prevalent.
I see. So basically, prevalence is a snapshot, whereas morbidity. What's the other one you said? Incidence is kind of a range of time. Or no? Huh? Grog? Sorry,
All
guys.
right.
Grog's back. We had a Wi-Fi thing. So prevalence is a snapshot in time, basically, whereas mortality is how many people straight up die, whereas morbidity is like how it affects them, and incidence is like a range in time.
Jumping back into it for the podcast crew. Nice save on the Wi Fi excuse, by the way.
It's not an
Let's
excuse,
clear
it's true, it's true, dude.
up. All right. Truth bomb accepted. Wi Fi drama is real. Anyway, let's get back to prevalence, incidence, morbidity, and mortality for the podcast. Prevalence is that snapshot you mentioned. How many people have a condition at a specific moment? Incidence is new cases popping up over a time period. Morbidity is about how a disease messes with quality of life, like symptoms or disability. Mortality is the grim one. How many people die from it? Clear enough? Or you want me to dig deeper?
No, that makes sense. I'm just wondering, how exactly do the names relate to the thing they're explaining?
Cool. Glad we're on the same wavelength. Now, about those names and how they tie to what they describe. It's kind of like they're wearing name tags that hint at their job. Prevalence comes from Latin roots, meaning to be widespread, so it fits that snapshot of how common a condition is right now. Incidence stems from to fall upon, like new cases dropping into the picture over time. Morbidity traces back to disease or sickness in Latin, pointing to how a condition screws with health or daily life. Mortality's no surprise. It's from death, straight up about the endgame. The names are like old school clues baked into the words. Want me to break down anything else for the pod?
No, that makes sense. Hmm. So how does COPD affect all these areas?
All right. Let's dive into COPD and how it hits prevalence, incidence, morbidity, and mortality. COPD, or chronic obstructive pulmonary disease, is a lung condition that makes breathing tough. Prevalence wise, it's pretty common. About 392 million people globally have it, especially older adults and smokers. Incidence depends on the region, but new cases keep climbing due to smoking, air pollution, and aging populations. Morbidity's rough. Think chronic coughing, shortness of breath, and fatigue that can limit daily life, like climbing stairs or even getting dressed. Mortality's serious. COPD's one of the top causes of death worldwide, claiming around 3 million lives yearly, often from complications like respiratory failure. Anything specific you want to zoom in on for the podcast?
Um, so, um, sorry guys, this has been a lazy start for me this morning. I'm just wondering how it affects the economy, COPD.
No worries. We're getting into the groove now. Lazy starts still make great podcasts. So, you're curious about how COPD impacts the economy. It's a heavy hitter. Globally, COPD racks up massive costs. Think hundreds of billions of dollars annually. Direct costs come from hospital stays, meds like inhalers, and doctor visits, especially when exacerbations flare up. Indirect costs are sneaky but huge. Lost productivity from people missing work or retiring early due to symptoms. Caregivers also take a hit, spending time and money supporting loved ones. Plus, there's the ripple effect on families and communities when folks can't contribute as much. Want me to break it down further, or maybe focus on a specific angle
No,
for the show?
that makes sense. Well, so what
Alright,
are some
cool.
environmental risk factors for COPD?
All right. Solid question to keep the podcast rolling. Environmental risk factors for COPD are a big deal. Cigarette smoke is the top villain. It's the leading cause, with long-term exposure damaging lung tissue. Secondhand smoke's also a sneaky culprit. Air pollution, like smog, vehicle exhaust, or industrial fumes, ramps up risk, especially in cities. Indoor pollutants hit hard too. Think biomass fuels like wood or coal used for cooking in poorly ventilated homes, super common in some regions. Occupational hazards like dust, chemicals, or silica exposure in jobs like mining or construction can also mess with lungs over time. Even long-term exposure to allergens or irritants can chip away at lung health. Want me to dive into any of these specifically for the pod?
You don't need to say the word pod all the time because it kind of breaks the fourth wall. I tell you this every episode. Um, so, can you explain a bit the biomass exposure and a bit more with as an environmental risk factor?
Haha, my bad. Slipping on that fourth wall again. Gotta keep the vibe immersive, I hear ya. Let's zoom in on biomass exposure as an environmental risk factor for COPD. Biomass fuels, like wood, crop residues, dung, or coal, are burned for cooking or heating, often in developing countries where gas or electricity isn't widespread. This happens indoors, usually on open fires or basic stoves with poor ventilation. The smoke's packed with toxic particles and chemicals that irritate and inflame the lungs. Over years, this constant exposure scars lung tissue, narrowing airways and hiking COPD risk, especially for women and kids who spend more time around these fires. It's a massive issue, linked to millions of COPD cases globally, alongside other lung problems. Anything else you want me to unpack about this?
Well, That makes sense. So biomass, I don't even know what biomass is, to be honest.
No sweat. Let's clear that up. Biomass is organic material used as fuel, stuff like wood, animal dung, crop leftovers, or charcoal. In the context of COPD, we're talking about burning these in homes, often in places where people rely on them for cooking or heating, because modern fuels aren't available or affordable. When you burn biomass, it releases thick smoke full of fine particles and nasty chemicals. Breathing that in day after day, especially in a small, poorly ventilated space, hammers the lungs, setting the stage for COPD. It's like a slow, invisible attack on your airways. Want me to go deeper into any part of this, or maybe tie it to something else you're thinking
No, that's
about?
good. So, and we also have genetic factors. Factors. What is pathobiology?
All right. Nice pivot to genetics and pathobiology. Keeping it rolling. Pathobiology is basically the study of how diseases develop and mess with the body at a biological level. For COPD, it digs into what's happening in the lungs and beyond. Think cellular and molecular changes. It's about how things like chronic inflammation, damaged lung tissue, and messed up repair processes lead to airways getting blocked or alveoli, those tiny air sacs, breaking down. Genetic factors tie in here. Some folks inherit mutations, like alpha 1 antitrypsin deficiency, which makes their lungs more vulnerable to damage from smoke or pollutants. Pathobiology also looks at how genes and environment team up to drive the disease, from mucus overproduction to weakened lung defenses. Want me to zoom in on the genetic angle or any specific part of
No,
this?
that makes sense. Okay, since we're multitasking topics, let's jump to the other topic we're talking today, pharmacokinetics. So let's start some. So, what are pharmacokinetics?
Smooth switch, multitasking like a pro. Pharmacokinetics is all about how a drug moves through the body, what happens from the moment you take it to when it's gone. It's got four main parts: absorption, how the drug gets into your bloodstream, like through your gut or lungs; distribution, how it spreads to tissues and organs; metabolism, how your body breaks it down, usually in the liver; and excretion, how it's cleared out, mostly through kidneys. Think of it as the drug's journey: how fast it kicks in, how long it sticks around, and why doses vary. Want me to connect this to COPD meds or break down any part more?
Um, I want to ask about the rights of prescribing. We have six rights. Huh?
Great topic. These are the key checks to make sure meds are given safely. Right patient, confirming you're treating the correct person. Right drug, picking the exact medication ordered. Right dose, getting the amount spot on. Right route, using the proper method like oral or inhaler. Right time, giving it when scheduled. And right documentation, recording everything accurately.
Right outcome. But I'm just wondering why right route? I don't understand this route.
Fair catch, and good call on right outcome. Let's unpack right route since it's tripping you up. Right route means making sure the drug is given the way it's supposed to be, like swallowing a pill, inhaling a mist, or getting an injection. It matters because the route affects how the drug gets absorbed and works. For COPD, say, an inhaler hits the lungs directly for fast relief. But if you gave that same drug as a pill by mistake, it might not work as well or could take longer. Wrong route can mess up the whole plan, maybe even cause harm. Does that clear it up? Or you want more on why routes are such a big deal?
I don't understand. If you could tell me again, please.
No problem. Let's hit it again, nice and clear. Right route is about giving a drug the exact way it's meant to be taken, like through the mouth, an inhaler, a shot, or even a patch. Each route changes how fast and how well the drug gets into your system. For example, with COPD, an inhaler delivers medicine straight to your lungs for quick action. If you use the wrong route, like swallowing an inhaler med instead, it might not reach the lungs properly, or could do nothing at all. It's about matching the method to the drug's design. Make sense now, or once?
Yeah, that kind of makes more sense.
Sweet, glad it's clicking. So, sticking with the 6 rights or anything else on prescribing you want to dive into? Maybe how routes play out with specific COPD meds, or something totally different?
Um, so I want to ask you about so like how a drug goes to the market. So we do some basic research and then we develop it and then we kind of introduce it and then what? We surveil, we do clinical tests, preclinical. We seem to, if you could kind of show us phase 1, phase 2, phase 3, phase 4.
All right, let's walk through how a drug gets to market. Great question for the show. It's a long road, starting with basic research, where scientists dig into a disease like COPD to find a target, maybe a new molecule. Then comes development, turning that idea into a drug.
Tell me more about it.
My bad, didn't mean to cut short there. So, let's dive deeper into how a drug hits the market from start to finish, focusing on those phases you mentioned. It all kicks off with basic research. Scientists studying a disease like COPD, figuring out what causes it, maybe zeroing in on a protein or pathway to target. They tinker in labs, coming up with potential compounds. That's the discovery phase. Super early takes years. Next, they move to development, preclinical testing. Here, they test those compounds in labs, on cells or animals, to see if they're safe and if they work at all. No humans yet. It's about weeding out duds. Then come the clinical trials, broken into phases. Phase 1 is the first human test, small group, maybe 20 to 100 healthy volunteers. It's all about safety. Does the drug cause bad side effects? They're checking how it's absorbed, metabolized, excreted. Think pharmacokinetics we talked about earlier. Phase 2 ramps up. Hundreds of patients with a condition like COPD. Now they're testing if the drug actually helps, say, improving breathing, while still watching for side effects. Doses get tweaked here. Phase 3 is the big one. Thousands of patients across multiple sites. It's about proving the drug works well, comparing it to existing treatments or placebos. This is make or break for approval. Regulators like the FDA pore over this data. If it passes, the drug gets approved and hits the market. But it doesn't stop. Phase 4 is post-market surveillance. Companies keep tracking it for long-term effects, rare side effects, or real-world performance as more people use it. Whole process can take 10 to 15 years, costs billions, and most drugs don't even make it through. Want me to zoom in on any phase or maybe tie it to a COPD drug example?
I want to ask guys, you might find this interesting too. What's the difference between REM sleep and deep sleep?
Nice curveball. Love the switch to sleep talk. Sure, the listeners will dig it. REM sleep and deep sleep are different stages of sleep, each doing its own thing for your body and brain. REM, or rapid eye movement sleep, is when your eyes twitch under your lids and your brain's buzzing with vivid dreams. It's key for memory processing, learning, and emotional regulation. Happens more toward the end of sleep cycles, roughly 20 to 25% of your night. Deep sleep, also called slow wave sleep, is the heavy, restorative stage earlier in the night, where your body's like, time to rebuild. It repairs tissues, boosts immunity, and recharges energy, about 15 to 20% of sleep. You're basically out cold here, super hard to wake. So, REM's for your mind, deep sleep's for your body. Want me to dig into how they affect health? Or maybe connected to COPD somehow?
No, that makes sense. That makes sense. Thank you. Okay. Um, if we go back now to pharmacokinetics, so in a sentence, could you summarize each phase?
All right, swinging back to pharmacokinetics. Nice flow. Here's a quick sentence for each phase to sum it up. Absorption is how a drug enters your bloodstream, like through your gut after swallowing a pill. Distribution is how that drug spreads to your tissues and organs, hitting the spots it needs to work. Metabolism is your body breaking the drug down, usually in the liver, to process it.
No, I mean the phases with the clinical trials and all.
Oh, my bad. Got wires crossed there. Thanks for the redirect. All right, clinical trial phases in one sentence each. Phase 1 tests a drug's safety and how it moves in the body, with a small group of healthy volunteers. Phase 2 checks if the drug works for the condition, like COPD, in hundreds of patients while tweaking doses. Phase 3 proves the drug's effectiveness and safety in thousands of patients compared to other treatments. Phase 4 monitors the drug after market approval to catch long-term effects or rare issues. Want me to tie these to pharmacokinetics or something else?
No, this makes sense. Let me ask you about what's the difference between pharmacokinetics and dynamics? So pharmacokinetics and pharmacodynamics, what's the difference?
Great question. Diving into the nitty-gritty. Pharmacokinetics is about what the body does to a drug, how it absorbs, distributes, metabolizes, and excretes it, like we talked about earlier. Pharmacodynamics, on the other hand, is what the drug does to the body, how it works, like targeting a receptor to ease COPD symptoms or lower inflammation. So, kinetics tracks the drug's journey, dynamics is about its impact. Make sense? Or want me to give an example to lock it in?
No, actually, yeah, give us an example.
Cool, let's make it concrete with an example. Say you're using an inhaler for COPD, like albuterol. Pharmacokinetics is the story of how the drug gets from the inhaler into your lungs, absorbs into your bloodstream, spreads to airway muscles, gets broken down by the liver, and eventually leaves through urine. Pharmacodynamics is what albuterol does once it hits those airway muscles. It binds to receptors, relaxes the muscles, and opens your airways so you can breathe easier. Kinetics is the travel plan. Dynamics is the job it does. Clear in now, or
Yeah.
want another?
Yeah, that's a good. Okay, so we have the drug going in, and so I guess it goes to the site of action, and then it has an effect, and the drug goes out.
Exactly. You nailed the flow. The drug goes in, travels to the site of action. That's the pharmacokinetics part, getting it where it needs to be. Then it does its job, like easing symptoms or fixing something. That's pharmacodynamics kicking in. After that, the body clears it out, wrapping up the kinetics again. Want to dig deeper into any part of that process?
So what
Or
are
maybe-
the three journeys then?
All right, I think you're asking about the journey of a drug, but your mention of 3 journeys might be throwing me a bit. Let's clarify.
Like the production, prescribing, monitoring.
Gotcha. Thanks for clarifying. You're talking about the 3 key stages in a drug's life cycle: production, prescribing, and monitoring. Let's break it down. Production is the process of developing and manufacturing the drug, from lab research through clinical trials, like those phase 1 to 3 we covered, to getting it made in factories, ensuring it's safe and effective. Prescribing is when a doctor chooses that drug for a patient, nailing the 6 rights we talked about: right patient, drug, dose, route, time, and documentation, to treat something like COPD. Monitoring happens after prescribing, tracking how the drug works in the patient, watching for side effects or benefits, and even post-market surveillance, phase 4, to catch long-term issues. Each stage is a leg of the drug's journey from idea to real world use. Want me to zoom in on one of these or connect it to something else?
Hmm. Okay. So, um, so
Sounds like you're mulling it over.
wait, wait.
Anyway,
So basically, pharmacokinetics is okay. Uh, I get it. I think I get it. So let's start with absorption then. Absorption and pharmacokinetics, how are they related?
all right, let's lock in on absorption and pharmacokinetics. Nice focus. Pharmacokinetics, as we said, is the whole deal of how a body handles a drug: absorption, distribution, metabolism, and excretion. Absorption is the first step of that journey. It's how the drug gets from where you take it, like an inhaler for COPD, into your bloodstream. For example, when you puff on an albuterol inhaler, the drug hits your lungs, crosses into the blood, and starts working. Absorption speed and efficiency depend on the route. Inhalers are fast for lungs, pills slower through the gut. It's a key piece of pharmacokinetics because if the drug doesn't get absorbed well, it can't do its job. Want me to dive?
Uh, so when it comes to administrating, we have oral, rectal, we have sublingual, buccal. Can you explain this?
All right, let's break down these routes of medication administration. Oral is the most common swallowing pills, liquids, or capsules that go through your digestive system. Rectal involves suppositories or enemas inserted into the rectum, often for local effects or when oral isn't an option, like with nausea. Sublingual means placing a drug under the tongue to dissolve and absorb directly into the bloodstream, bypassing the stomach for fast action. Think nitroglycerin. Buccal is similar but involves placing the drug between the cheek and gum for absorption through the oral mucosa, often for sustained release. Each method has its perks depending on the drug and condition. Anything specific you want to dive deeper into?
I just wonder where the word buccal comes from.
The word buccal comes from Latin, specifically bucca, which means cheek. It refers to the area inside the mouth along the cheek. So when we say buccal administration, it's about placing a drug there to absorb through the cheek's lining. Pretty straightforward once you trace it back. Want to explore anything else about it?
No, that makes sense. Um, so what are factors that affect uh, the enteral absorption, let's say?
Cool. Let's talk about what affects how drugs get absorbed internally. For oral administration, things like stomach acid, food in your gut, or digestive enzymes can speed up or slow down absorption. Some drugs absorb better with food, others on an empty stomach. Blood flow to the absorption site matters a lot. Sublingual and buccal routes get drugs into the bloodstream fast because the mouth has tons of blood vessels. Drug form also plays a role. Tablets might dissolve slower than liquids or sublingual tabs. Then there's your body's metabolism. Liver enzymes can break down drugs before they fully absorb, especially with oral meds. Other factors, your age, gut motility, or even diseases like Crohn's can mess with absorption. Anything specific here you want to zero in on?
Um, Not really. So the GI motility, the GI blood flow, these affect the particle size of the drug. This makes sense. Um, what about things like the drug's properties, like the solubility, if it's lipid soluble or if it's hydrophilic?
Yeah, you're hitting on some key points. The chemical properties of a drug, like solubility, massively affect how it gets absorbed. Lipid soluble drugs slip through cell membranes easily, especially in places like the gut or mouth, since membranes are fatty. Think drugs like diazepam. They're fat loving and absorb fast. Hydrophilic drugs, water soluble ones, need specific transport mechanisms or channels to cross membranes, which can slow things down unless they're in a watery environment like the stomach. Solubility also ties to particle size and dissolution rate. Smaller particles of poorly soluble drugs dissolve quicker, boosting absorption. pH matters too. Some drugs absorb better in acidic stomachs, others in the alkaline intestines. It's like a chemistry puzzle in your body. Want me to dig into any of these
I
properties
was
more?
wondering why hydrophilic are ionized and lipid soluble are non ionized.
Great question. Let's unpack that. Hydrophilic drugs, which love water, often ionize because they carry a charge or easily gain lose electrons in aqueous environments like your body's fluids. Think of electrolytes or drugs like metformin. This ionization makes them less likely to slide through fatty cell membranes, which are nonpolar. Lipid soluble drugs, on the other hand, are typically non ionized because they're neutral, lacking a charge, which lets them dissolve into the lipid rich membranes easily, like how oil mixes with oil. Think of something like testosterone. It's fat loving and non polar, so it crosses membranes without needing help. The degree of ionization often depends on the drug's chemical structure and the pH of the environment it's in. Does that clear it up, or want me to dive deeper into the chemistry?
Well, I don't understand, to be honest. And I don't even understand also why a lipid soluble drug will have a greater absorption.
No worries. Let's break it down simpler. Cell membranes in your body, like in the gut or mouth, are made of a fatty lipid bilayer. Think of it like a greasy barrier. Lipid soluble drugs, like oil, blend right into this fatty layer because they're nonpolar and neutral, non ionized. They don't carry a charge, so they slip through the membrane easily, leading to faster and greater absorption. Picture pouring oil into a pan, it spreads smoothly. Hydrophilic drugs, which mix well with water, often ionize, meaning they pick up a charge, like sodium ions. This charge makes them stick to water and repel the fatty membrane, so they can't cross as easily. They need special channels or transporters, which slows absorption. It's like trying to push a water droplet through grease. It doesn't move smoothly. So, lipid soluble drugs, like ibuprofen, get absorbed quicker because they match the membrane's fatty nature. Hydrophilic drugs, like some antibiotics, struggle unless the body helps them across. Want me to clarify any part or use an analogy to make it click?
Um, it's alright. So, what other factors influence absorption? For instance, if the pH, does the pH affect? Um, yeah, if you and give us an example of aspirin, let's say, and diazepam, because of it, and yeah.
All right, let's dive into how pH and other factors influence drug absorption using aspirin and diazepam as examples. pH is a big player because it affects whether a drug is ionized or non ionized, which we talked about earlier. Aspirin is a weak acid, so in the stomach's acidic pH, around 1 to 3, it stays mostly non ionized, slipping easily through the stomach's fatty membranes for decent absorption. But in the intestine, where pH is higher, more neutral, around 6 to 8, aspirin ionizes more, slowing its absorption unless it's carried along by the intestine's huge surface area, which is why most of it absorbs there anyway. Diazepam, a lipid soluble, neutral drug, isn't as picky about pH. It stays non ionized in both stomach and intestine, absorbing quickly either way because it loves fatty membranes, regardless of the environment. Beyond pH, other factors matter. Surface area, like I said, the intestine's massive surface area boosts absorption for most drugs. Blood flow also counts. Areas like the mouth, sublingual, buccal, or intestines have great blood flow, pulling drugs into circulation fast. Drug form matters too. Liquid diazepam absorbs quicker than a tablet. Gut motility can speed or slow things. Faster movement might reduce absorption time for aspirin. Food in the stomach can delay aspirin's absorption by slowing gastric emptying, but might not bug diazepam as much, since it's so lipid friendly. Lastly, your body's metabolism, like liver enzymes, can nab some drugs before they fully absorb, though diazepam's less affected here than aspirin. So, pH tweaks how aspirin behaves across your gut, while diazepam's just chilling, absorbing easily. Anything else you want to nail down about these factors?
Well, I'm kind of wondering about if you could tell me in a sentence why acidic drugs are better excreted in basic media.
Acidic drugs are better excreted in basic media because, in a higher pH, they ionize more, becoming charged and water soluble, which helps your kidneys filter and flush them out faster. Want me to expand on that at all?
Sure. Sure.
All right, let's flesh this out a bit. Acidic drugs, like aspirin or ibuprofen, have a chemical structure that makes them more likely to lose a proton and become ionized in basic alkaline environments, like urine with a higher pH. When they're ionized, they carry a charge which makes them super water soluble and less likely to slip back into fatty tissues or reabsorb into the bloodstream through the kidney's tubules. Your kidneys are great at filtering out water-soluble, charged particles, so this ionization traps the drug in the urine, speeding up excretion. In acidic urine, these drugs stay more non-ionized, meaning they're less charged, more lipid-soluble, and can get reabsorbed into the body, slowing excretion. That's why doctors might alkalinize urine, like with sodium bicarbonate for overdoses of acidic drugs to flush them out faster. Clearer now, or want me to hit another angle?
I don't get it.
No problem. Let's simplify it even more. Picture an acidic drug, like aspirin, is a molecule that can either be neutral or carry a charge, depending on the environment. In basic, alkaline urine, which has a high pH, aspirin picks up a charge. Think of it like a magnet sticking to water. This charged form can easily cross back into your body's fatty tissues or blood because it's trapped in the watery urine, so your kidneys flush it out quickly. In
So
acidic
it's
urine,
like plus and minus that the acidic are better excreted in basic.
to continue neutral and less magnet-like, so it can sneak back into your blood instead of staying in the urine to be peed out. Yeah, you're kind of on the right track with the plus and minus idea. Think of it this way.
All
Acidic
right, that's
drugs,
fine. So what are when I want to put a drug um, and a parenteral, I can do it intramuscular, I can do it subcutaneous, I can do it intravenous, intradermal. I'm just wondering, is it the angle? Is it just we're learning how to do the angle? How do we know like where it went through?
got it. You're diving into parenteral routes. Those are ways to deliver drugs bypassing the gut, like intramuscular, subcutaneous, intravenous, and intradermal. The angle of injection does matter, but it's not the whole story. Let me break it down. Each method targets a specific tissue layer, and the angle, needle length, and technique help ensure the drug lands where you want it. Intramuscular, IM, goes deep into muscle tissue, like in your arm or butt, at a 90-degree angle, with a longer needle, usually 1 to 1.5 inches. You know it's in the muscle because you feel the resistance of the tissue and aim for thick muscle areas. Subcutaneous, sub-Q, hits the fatty layer just under the skin, using a shorter needle, about 0.5 to 1 inch, at a 45-degree angle, or 90 if you pinch the skin. You can tell it's right because it's a shallow injection and you don't hit muscle. Intravenous, IV, goes straight into a vein. No angle really, since you're threading a needle or catheter directly into the bloodstream. Confirmed by
What
blood
does
flow.
subcutaneous mean? What does cutane mean? Cutaneous. Alrighty, let's continue. So I want to also ask, we can also have like topical route as route of drug administration or transdermal, intra intrathecal, if you could explain intrathecal for us, inhalational.
All right, we're back in action. Let's dive into these routes of drug administration, focusing on intrathecal and touching on topical, transdermal, and inhalational. Intrathecal means delivering a drug directly into the spinal canal, specifically into the cerebrospinal fluid around your spinal cord. Think of it like injecting meds, like anesthetics or chemo drugs, right into the space under the spinal cord's protective layers using a needle, usually via a lumbar puncture. It's super targeted for things like spinal anesthesia or treating CNS infections because it bypasses the blood brain barrier. Topical is applying drugs to a surface, like creams on skin or drops in eyes for local effects.
Sorry, in a
Trans
sentence, tell me again what is intrathecal?
Intrathecal administration delivers drugs directly into the cerebrospinal fluid in the spinal canal for targeted effects on the spinal cord or brain. Want me to clarify anything else?
Um, yes, intrathecal. I still don't understand. If you could give us the etymology too, maybe it would help me.
No problem. Let's break down intrathecal even more.
Yeah. Let's do it.
All right, let's dive in. What's the first thing you want to tackle?
Intrathecal, sir. Intrathecal. What does it mean?
Intrathecal refers to something delivered directly into the spinal canal.
Okay.
Usually,
Okay. But what the thecal? Where does the word thecal come from?
the word thecal comes from the Greek word theke, which means a case or sheath. In medical terms, it refers to the sheath-like space around the spinal cord.
And what is this? The spinal canal is like the thing around the spinal cord, right?
Yeah, exactly. The spinal canal is the bony tube in your spine that houses the spinal cord, and it's surrounded by protective layers,
Okay.
including that.
Makes sense. So let me go back to COPD and let me ask you about pathophysiology now. So we have airflow obstruction, gas trapping. Can you explain though things like hyperinflation and why we have gas exchange abnormalities and maybe pulmonary hypertension, exacerbations, multimorbidity?
All right, let's break down the pathophysiology of COPD. You mentioned airflow obstruction and gas trapping, which are core to COPD, so let's build on that. Hyperinflation happens because of the airflow obstruction, mostly from narrowed airways due to inflammation, mucus buildup, and loss of elastic recoil in the lungs. When you can't fully exhale, air gets trapped in the alveoli, making the lungs overinflate. This flattens the diaphragm, making it harder to breathe, and you feel short of breath all the time. Gas exchange abnormalities come from damage to the alveoli, especially in emphysema type COPD. The alveolar walls get destroyed, reducing the surface area for oxygen to enter the blood.
But
and
why
carbon
in
dioxide.
hyperinflation we have gas volume in the lung increasing?
In hyperinflation with COPD, the gas volume in the lungs increases because the airways are obstructed and the lungs lose their elastic recoil. Typically, when you exhale, the
I see.
lungs.
That makes sense. And what about exacerbations and hypertensions? Explain us hyperplasia too while we're at it.
All right, let's dive into those. Exacerbations in COPD are sudden worsening of symptoms, like more shortness of breath, cough, or mucus production, often triggered by infections, pollution, or even stress. They happen because the already inflamed airways get even more irritated, leading to further narrowing and mucus buildup, making breathing tougher. Pulmonary hypertension in COPD comes from long-term low oxygen levels in the blood. This stresses the blood vessels in the lungs, causing them to constrict and thicken over time, which increases pressure in the pulmonary arteries and strains the heart. Now, hyperplasia, you might mean hypertrophy here, but let me clarify. Hyperplasia is an increase in cell number, not typically a big player in COPD lungs. Instead, we often see hypertrophy, like in the airway smooth muscles or mucus glands, where cells get bigger or multiply due to chronic irritation and inflammation. If you meant hyperplasia specifically, it could refer to goblet cell hyperplasia, where more mucus producing cells form in the airways, clogging things up.
What is
Did I
exacerbation?
An exacerbation in COPD is a sudden flare up where symptoms like shortness of breath, coughing, or mucus production get worse than usual. It's often triggered by infections, like a cold or pneumonia, or environmental factors like smoke, and it can make breathing much harder, sometimes needing urgent treatment.
Hmm. Okay. So, how does it look like?
An exacerbation of COPD looks like a noticeable worsening of your usual symptoms. You might be coughing more, producing thicker or more mucus, feeling extremely short of breath even at rest, or having chest tightness. It can also come with fatigue, fever if there's an infection, or even confusion in severe cases.
What's a non-productive cough?
A non-productive cough is one way you're coughing, but not bringing up any mucus or phlegm. It's dry. In COPD, it can happen during an exacerbation or from irritation in the airways, unlike a productive cough where you're clearing out gunk.
Hmm. So, if I want to diagnose someone with COPD, what do I do?
To diagnose COPD, start with the patient's history. Ask about symptoms like chronic cough, shortness of breath, or mucus production, and check for risk factors like smoking or exposure to pollutants. Then, do a spirometry test. It's the gold standard. It measures how much air they can exhale and how fast, showing airflow obstruction if the FEV1/FVC ratio is less than zero point 0.7 after a bronchodilator. You might also order a chest x-ray or CT scan to rule out other conditions, and check oxygen levels with a pulse oximeter. If symptoms and history align with spirometry results, that's usually enough to confirm COPD.
Tell me more about this spirometry.
Spirometry is a simple test that measures lung function, key for diagnosing COPD. The patient takes a deep breath and blows as hard and long as they can into a tube connected to a machine. It records two main numbers, FEV1, the amount of air exhaled in 1 second, and FVC, the total air exhaled. In COPD, the airways are obstructed, so the FEV1/FVC ratio is lower than zero point 0.7, even after using a bronchodilator. It's quick, done in a doctor's office, and shows how severe the airflow limitation is.
Hmm. Okay, so I'm gonna do spirometry and then FEV1, FVC ratio. Explain us why we do this ratio.
The FEV1 FVC ratio in spirometry tells us how well air moves out of the lungs. FEV1 is the volume of air you can forcibly exhale in 1 second, and FVC is the total volume you can exhale fully. Typically, you should exhale most of your air quickly, so a healthy ratio is around zero point 0.7 or higher. In COPD, airflow is blocked due to narrowed airways or damaged lungs, so FEV1 drops more than FVC, making the ratio less than 0.7. This ratio pinpoints obstruction, helping confirm COPD versus other lung issues.
Hmm. Okay, and so so the FEV1 FVC ratio is basically how much of our air went in the first second.
Not quite, but you're close. The FEV1 FVC ratio isn't about how much air went in, but how much of the total air you can forcibly exhale.
Yes, how much air went into the machine, I mean.
Got it. You're talking about the air blown into the spirometer. Yeah, the FEV1 FVC ratio measures how much of the total air you exhale, FVC, comes out in the first second, FEV1. In COPD, because the airways are obstructed, you can't push out as much air quickly. So FV1 is low compared to FVC, giving a ratio below 0.7. It shows how blocked the airways are.
Mm-hmm. Okay, and we have like a severity grade for COPD, if you could explain it to us. So we have gold 1, 2, 3, 4.
All right, let's break down the COPD severity grades based on the GOLD system. GOLD stands for Global Initiative for Chronic Obstructive Lung Disease, and it uses spirometry, specifically the FEV1 percentage of predicted normal, to classify severity. Gold 1 is mild, where FEV1 is 80% or more of predicted. You might have a cough, but not much trouble breathing. Gold 2 is moderate, FEV1 between 50% and 79%. Shortness of breath starts showing up, especially during activity. Gold 3 is severe, FEV1 30% to 49%. Breathing's tough, fatigue kicks in, and daily tasks get hard.
What does gold stand for?
GOLD stands for Global Initiative for Chronic Obstructive Lung Disease. It's an organization that sets guidelines for diagnosing and managing COPD worldwide.
Hmm. Okay, and if we take a look at imaging, what's pulmonary bulla?
A pulmonary bulla is a large air-filled space in the lung, usually bigger than 1 centimeter, caused by destroyed alveolar walls. In COPD, especially emphysema, the lung tissue breaks down, forming these thin-walled pockets that can trap air and make breathing harder. They're often seen on a CT scan and can sometimes cause complications like infections or a collapsed lung if they rupture.
Hmm. Okay, so they are small air-filled sacs.
Well, not exactly small. Pulmonary bullae are actually pretty big, typically over 1 centimeter, and can get much larger. They're air-filled pockets in the lung from damaged tissue, unlike the tiny alveoli, which are the normal air sacs. In COPD, these bullae form when alveolar walls break down, creating these larger, problematic spaces that mess with lung function.
Hmm. Interesting.
Yeah, it's wild how the lungs can change like that. So, what's next on your mind? Want to dig deeper into COPD or switch gears?
Can we talk about the COPD value pyramid? So, in terms of money.
Sure thing. Let's talk about the COPD value pyramid from a financial angle. The COPD value pyramid is a model that ranks interventions for COPD based on their cost effectiveness, measured as cost per quality adjusted life year, or QALY. At the base, you've got low cost, high impact stuff like smoking cessation programs and flu vaccinations. These are cheap and prevent a lot of problems, giving you big bang for your buck. Moving up, things like pulmonary rehab and proper inhaler therapy cost more, but still add solid value by improving breathing and cutting hospital visits. Higher up, you hit more expensive interventions like long term oxygen therapy or surgery for severe cases. These help, but the cost per quality climbs. At the top, you've got the priciest options, like managing complex cases or end of life care,
Like
which could
I was just asking, like telehealth, triple therapy, LABA, tiotropium. Can you explain these to us?
All right, let's dive into those COPD treatments and options. Telehealth for COPDs using tech like video calls or remote monitoring to manage patients. It's handy for checking symptoms, adjusting meds, or guiding rehab without needing in person visits, saving time and money, especially for those far from clinics. Triple therapy combines three types of inhalers for severe COPD: a long acting beta agonist, LABA, a long acting muscarinic antagonist, LAMA, and an inhaled corticosteroid, ICS. It's used when symptoms aren't controlled by fewer meds, helping open airways and reduce inflammation, but it's pricier and has side effect risks like pneumonia. LABA, like salmeterol, relaxes airway muscles to ease breathing, taken daily for long term control. Tiotropium, a LAMA, works similarly but targets different receptors, relaxing airways and cutting mucus. It's often a go to for maintenance, with once daily dosing. Each of these fits into the COPD value pyramid differently. Telehealth and
Did Einstein go to uni?
Yeah, Albert Einstein did go to university. He studied at the Polytechnic Institute in Zurich, Switzerland, starting in 1896. He earned a degree in physics and mathematics in 1900, though he wasn't exactly a straight A student, focused more on ideas than grades. Want me to dig into anything
What do you mean
specific?
focused more on ideas than grades?
Einstein was more into chasing big questions than chasing perfect scores. At the Polytechnic, he often skipped lectures to study physics on his own or tinker with experiments, which annoyed some professors. His grades were solid but uneven. He aced physics and math but slacked on other subjects.
What other
He-
subjects?
At the Polytechnic, Einstein had to take courses beyond physics and math, like chemistry, engineering drawing, and even some humanities stuff like languages and history. He wasn't thrilled about them and put less effort there, sometimes barely passing. His focus stayed on unraveling the mysteries of physics, which he studied obsessively on his own terms. Anything else you want to explore about his time at
No, I was just wondering. Okay, so how do we stop smoking? Because this is like an easy way to kind of, not an easy, but this would help with COPD.
You're spot on. Quitting smoking is one of the best ways to slow COPD progression, though it's not always easy. First, set a clear goal and pick a quit date to commit to. Nicotine replacement therapies like PAP.
It's not for me, it's for like how, if you're a doctor, how you help patients.
Got it. As a doctor helping patients quit smoking to manage or prevent COPD worsening, you take a structured approach. Start with a frank talk about how smoking drives COPD progression. Make it personal, tying it to their symptoms like shortness of breath. Assess their readiness to quit using motivational interviewing, asking open ended questions like, what makes you think about quitting? Then, recommend a combo of behavioral support and meds. Suggest nicotine replacement therapies, patches, gum, or lozenges, or prescription drugs like bupropion or varenicline, explaining how they cut cravings or withdrawal. Point them to counseling or quit lines for regular check ins, and consider group programs or apps for extra support. Follow up often, like every few weeks, to tweak the plan and share their progress, even small wins. If they slip, reframe it as a learning moment, not failure, and keep them focused on the next try. Tailor it to their life, budget, stress, triggers to make it stick. Anything specific about this you want to dive into?
No, it's good, but let's talk a bit about vaccinations too that would help with COPD. So, like influenza, pneumococcal vaccinations, COVID-19.
Vaccinations are a key tool for managing COPD because they cut the risk of infections that can trigger exacerbations. The influenza vaccine, or flu shot, is a must get yearly. Flu can hit COPD patients hard, causing severe breathing issues, so it reduces hospitalizations and flare ups. The pneumococcal vaccine, like PCV13 or PPSV23, protects against bacterial pneumonia, another big COPD complicator. It's usually given once or in a series, depending on age and health status matters, so check their history. For COVID-19, the vaccine is critical since the virus can be brutal on lungs already damaged by COPD. Keep them updated with boosters as advised. Push these vaccines during routine visits. Explain they're like armor for the lungs, and address hesitancy by tying it to fewer ER trips. Any part of this you want more on?
No, that makes sense. Can we talk about pulmonary rehabilitation a bit too?
Absolutely. Pulmonary rehabilitation is a game changer for COPD patients. It's a structured program, usually a few weeks long, combining exercise, education, and support to improve breathing and quality of life. The exercise part, like treadmill walking or stationary cycling, builds endurance and strengthens muscles, especially those used for breathing, tailored to the patient's ability. Education covers stuff like proper inhaler use, nutrition to stay strong, and spotting early signs of exacerbations. There's also a big focus on coping skills, like breathing techniques or managing anxiety, since feeling short of breath can be scary. It's done in a group or hospital setting with pros like respiratory therapists guiding it. Studies show it cuts hospital visits and boosts energy, though patients need to keep up some exercises at home to maintain gains. Want me to zoom in on any specific part of it?
Um, so it's okay. Let me ask you about pharmacological management then. So inhaled therapy, prophylactic antibiotics, oxygen therapy, ventilatory support, interventional therapies. Could you tell us a bit about each of these and then maybe quiz us?
All right, let's break down the pharmacological and related management options for COPD. Then I'll toss a quick quiz your way. Inhaled therapy is the cornerstone. You've got bronchodilators like LABAs, long-acting beta agonists, e.g., salmeterol, and LAMAs, long-acting muscarinic antagonists, e.g., tiotropium, to open airways and ease breathing, taken daily. Inhaled corticosteroids, ICS, e.g., fluticasone, reduce inflammation, often paired with LABAs for moderate to severe cases. Triple therapy, LABA plus LAMA plus ICS, is for those with frequent exacerbations. Short-acting versions, like albuterol, are for quick relief. Prophylactic antibiotics, like azithromycin, can be used long-term in some patients with frequent exacerbations to reduce bacterial infections. It's not for everyone due to risks like antibiotic resistance or side effects.
So
it's
why
carefully-
are bronchodilators like beta 2 agonists an inhaled therapy? Explain this SABA and LABA a bit more.
All right, let's dig into bronchodilators, specifically beta 2 agonists, and clear up LABA and LAMA. Bronchodilators relax the muscles around the airways in COPD, making it easier to breathe. Beta 2 agonists, one type, work by stimulating beta 2 receptors on airway smooth muscle, causing them to loosen up fast.
I see. And what about anti-muscarinics?
I'm guessing you meant untamed scarps.
No, I said anti-muscarinics, SAMA and LAMA.
Got it. My bad for the mix-up. You're talking about untamed Scaranex, Sama, and Llama. It sounds like you might be referring to something specific, maybe from a game, story,
Dude, I'm talking about COPD and inhaled therapies, and I'm talking about anti-muscarinics.
All right. My apologies for the confusion. Let's get on track. You're talking about COPD and inhaled therapies, specifically anti-muscarinics, and it seems you mentioned SAMA and LAMA, which stand for short-acting muscarinic antagonists and long-acting muscarinic antagonists, respectively. I'm not sure about untamed Scaranex, maybe a miscommunication or a term I'm unfamiliar with in this context. For COPD, inhaled antimuscarinics are key players. SAMAs, like apratropium, work quickly to relax airway muscles, helping with symptoms for a few hours. LAMAs, like tiotropium or glycopyrronium, last longer, often dosed once daily, and are great for maintenance therapy. They block acetylcholine, which reduces bronchoconstriction and mucus secretion. Recent developments include newer LAMAs like revefenacin, which can be delivered via nebulizer for patients who struggle with traditional inhalers. Combining LAMAs with long-acting beta agonists or even inhaled corticosteroids is also becoming more common for better control, especially in severe cases. If you meant something specific by untamed scaronyx or want me to dig deeper into a particular anti-muscarinic or therapy, let me know what's up.
That's so good.
What's
So let me ask you about it. So what is muscarinic in the first place, though?
No problem, let's break it down. Muscarinic refers to a type of receptor in your body, specifically muscarinic acetylcholine receptors. They're part of the nervous system and respond to acetylcholine, a chemical messenger. In the lungs, these receptors are found on airway smooth muscles and glands. When activated, they can cause the airways to tighten and produce more mucus, which is bad news for someone with COPD. Antimuscarinics, like the SAMAs and LAMAs we talked about, block these receptors, stopping that tightening and mucus buildup, making it easier to breathe. Think of muscarinic receptors as little switches that, when flipped, constrict airways. Antimuscarinics basically keep those switches off. If you want to dive deeper into how they work or something else, just say the word. What's next on your mind?
I was wondering about interventional therapies, bulectomy, lung transplantation, and endobronchial valves.
All right, let's dive into interventional therapies for COPD, focusing on bulectomy, lung transplantation, and endobronchial valves. These are typically considered for severe cases where medications and lifestyle changes aren't cutting it. A bulectomy is a surgery where large, damaged air sacs called bullae are removed from the lungs. These bullae can take up space and make breathing harder, especially in emphysema-heavy COPD. By taking them out, you can improve airflow and reduce symptoms, but it's only an option if the bullae are big enough and localized, which isn't super common. Lung transplantation is a heavier hitter, usually for very advanced COPD, like GOLD Stage 4, where lung damage is extensive. It involves replacing one or both diseased lungs with a donor's. It can significantly improve breathing and quality of life, but it's a major procedure with risks like rejection or infection. You've got to be healthy enough overall to qualify, and there's a wait list for donors, which can be tough. Endobronchial valves are less invasive. These are one-way valves placed via a bronchoscope into the airways of the worst affected lung areas,
Okay.
often in
So let's
emphysema.
go back to pharmacokinetics then. So we have the minimum effective concentration and the minimum toxic concentration, and then the middle ground is the ideal dose.
All right, let's pivot back to pharmacokinetics, focusing on minimum effective concentration, minimum toxic concentration, and that sweet spot in between. You're spot on with the concept. The minimum effective concentration, or MEC, is the lowest drug level in the blood that produces the desired therapeutic effect. Say for COPD meds like inhaled antimuscarinics, enough to relax airways without symptoms creeping back. The minimum toxic concentration, or MTC, is where the drug level gets too high, causing side effects like dry mouth, blurry vision, or worse with antimuscarinics. The middle ground, often called the therapeutic window, is where you want the dose to land, effective but safe. For inhaled therapies, pharmacokinetics gets tricky since they act locally in the lungs, and systemic absorption varies. Something like tiotropium, a LAMA, has a steady profile with minimal systemic side effects because it's designed to stay in the lungs longer. Getting the dose right depends on the inhaler type, patient technique, and lung function. If you're thinking about a
Okay.
specific drug,
Fair enough. So
all right.
when it
So,
comes to pharmacokinetic concepts, could you explain a bit first pass, bioavailability, bioequivalence? Yeah, let's start with those.
no worries. Let's unpack those pharmacokinetic concepts. First pass, bioavailability, and bioequivalence. First pass metabolism happens when a drug is absorbed, typically through the gut and goes straight to the liver via the portal vein. The liver can metabolize a chunk of it before it hits the bloodstream, reducing how much active drug makes it through. Inhaled COPD meds, like LAMAs or beta agonists, mostly dodge this since they go directly to the lungs, but oral meds, if used, get hit hard by first pass. Bioavailability is how much of the drug actually reaches systemic circulation to do its job, expressed as a percentage. For inhaled therapies, bioavailability is often low systemically because the drug stays in the lungs, which is good for minimizing side effects. Bioequivalence is about comparing two drugs, say a generic versus a brand name inhaler, to make sure they release the same amount of active ingredient at the same rate and have the same effect. This matters a lot when swapping meds to ensure you're getting the same relief. If you want to zoom in on how these apply to a specific COPD drug or go deeper, just let me know. What's sparking your interest next?
I want to ask about steady state, about clearance, and about the cytochrome P450 enzyme system.
All right, let's dive into steady state, clearance, and the cytochrome P450 enzyme system. Steady state is when the amount of drug going into your body, say through regular dosing of a COPD inhaler, like tiotropium, equals the amount being removed, so the drug level in your blood stays consistent. It usually takes about 4 to 5 half-lives of the drug to reach this point, and for long-acting COPD meds, this helps maintain symptom control. Clearance is how quickly your body gets rid of the drug, either by metabolizing it in the liver or excreting it through kidneys or lungs. For inhaled therapies, clearance is often slower since they're designed to hang out in the lungs, but any drug that gets into the bloodstream is cleared mostly by the liver. That brings us to the cytochrome P450 enzyme system, a group of enzymes in the liver that break down many drugs. For COPD, some oral meds, like theophylline, rely heavily on P450 enzymes, and things like smoking or other drugs can speed up or slow down this process, messing with drug levels. Inhaled meds bypass this system more, but systemic absorption can still involve P450 to a degree. If you're curious about how these play out for a specific COPD drug or want more detail, what's on your mind?
So bioavailability is like oral AUC over IV AUC. Could you explain this?
You're right. Bioavailability often ties to comparing the area under the curve, or AUC, for oral versus IV dosing. So let's break it down. The AUC measures the total drug exposure over time in your bloodstream. Think of it as a graph showing how much drug is available and for how long. When you give a drug intravenously, it goes straight into the blood, so it has 100% bioavailability, and its AUC represents the full dose. With oral drugs, things like first-pass metabolism in the liver or gut absorption can reduce how much drug actually reaches the bloodstream. Bioavailability is calculated by dividing the AUC of the oral dose by the AUC of the IV dose, then multiplying by 100 to get a percentage. For example, if an oral drug's AUC is half that of the same dose given IV,
I
its
don't understand this IV. What is this IV?
No problem. Let me clarify. IV stands for intravenous, which means giving a drug directly into a vein. When a drug is administered IV, it goes straight into the bloodstream, bypassing things like the stomach, intestines, or liver metabolism that can reduce how much drug gets through. That's why IV is considered 100% bioavailable. It's the full dose hitting the system immediately. In the context of bioavailability, we compare the AUC, or area under the curve, of an oral drug to the AUC of the same drug given IV to figure out what fraction of the oral dose actually makes it into circulation.
So I'm a bit confused why this is the case, though. Could you explain it in a sentence or two, like really simply and straightforward?
IV drugs go straight into your blood, so you get the full dose immediately. Oral drugs have to pass through the stomach and liver, which can break some of it down, so less reaches the blood.
Yeah, but I have this graph of the IV going down, and then the oral kept going up and then down.
That makes sense, and I can picture what you're seeing on that graph. With IV, the drug hits the bloodstream right away, so the concentration spikes high immediately, but then drops as the body clears it. That's why the graph trends down. For oral, it takes time to absorb through the stomach and intestines, so the concentration starts low, rises gradually as it enters the blood, peaks later, then drops as it's metabolized. That's why the oral graph climbs before falling, unlike the IV's quick spike and decline. If you're thinking about a specific drug or want
I
help
don't
with
get
what,
it. Could you explain this again?
no worries, let's make it super clear. When you give a drug IV, it's like pouring it straight into your blood. So the graph shows a big spike right away, then it falls as your body clears it. With an oral drug, it's like a slow soak. It takes time to get through your stomach and into your blood. So the graph starts low, climbs up to a peak, then drops as the drug gets used up. If you're still picturing that graph and it's tripping you up, maybe tell me what part's confusing.
It's
And I'll zero.
confusing me why it looks like that.
All right, let's zoom in on why the graph looks that way. Super simple. For IV, the drug floods your blood instantly, so the graph jumps to a high
You
point
know what
right.
would be good, dude, if we, you know how Socrates was teaching through questions? Maybe just ask me questions, and maybe hopefully I will learn the answer by this.
Love the Socratic vibe, dude. Let's roll with it. All right, picture that graph again. Why do you think the IV line shoots up so fast compared to the oral line? What's going on in the body to make that happen?
So the IV is because it's already in the body. It doesn't need to go through the body like the oral one.
You're on the right track. So, since the IV drug is already in the blood, what do you think causes its graph to drop after that initial spike? And for the oral drug, what's slowing it down from getting into the blood right away?
Well, the oral one has to pass through the lungs and stuff, right? No?
Close, but let's zero in. For the oral drug, it's not the lungs, but something else it passes through before hitting the blood.
The
What
GI?
exactly? The GI tract. So, how do you think the GI tract slows down the oral drug's journey to the blood, making that graph climb more gradually? And for the IV drug, any guess why its level drops off after hitting the blood so fast?
Can you repeat the question?
No problem. So, for the oral drug, what's happening in the GI tract that slows it down, making the graph rise gradually? And for the IV drug, why do you think its level drops after spiking so fast in the blood?
I don't know. I don't know. Can you tell me? I don't know.
All right, no stress. Let's keep it rolling with a nudge. Imagine the oral drug as a pill you swallow. Can you guess one thing that happens to it in your stomach or intestines that takes time before it gets to your blood? For the IV drug, think about what your body does with any drug in the blood. Like, where might it go to disappear from that graph? Any ideas popping up?
Well, I don't know. The oral, it means it is going to get digested and stuff in the GI first, whereas the IV is already in.
You're nailing the big picture. So, yeah, the oral drug gets digested in the GI. What do you think that digestion process involves that makes it take longer to show up in the blood compared to IV? And with the IV drug already in the blood, what might your body be doing to lower that level over time, making the graph drop?
Well, it's using the drug in the IV, and the oral is slowing down because the drug has to, I don't know, get broken down by enzymes and stuff.
You're piecing it together great. So, for the oral drug, you mentioned it getting broken down by enzymes and stuff. What part of the GI process, like in the stomach or intestines, do you think is soaking up or absorbing the drug to make it reach the blood slower? And for
The stomach.
good guess, the stomach does start the process, but most of the drug absorption actually happens a bit later. Can you think of what part of the GI tract after the stomach might be pulling the drug into the bloodstream,
The
slowing that graph's rise?
the duodenum.
Spot on. The duodenum. That's where a lot of drug absorption kicks in. So, why do you think it takes time for the drug to get absorbed in the duodenum and show up in the blood, making the graph rise slowly? And for the IV drug, since it's already in the blood, what's your guess on how the body's using it or making its level drop on the graph?
What?
All right, let's untangle that. You're saying both. So, let's break it down. For the oral drug in the duodenum, what's one thing that might slow its absorption into the blood, causing that gradual climb on the graph?
I'm tired of this game. Just give me the answers.
Fair enough. No problem. For the oral drug, it takes time to get absorbed in the duodenum because it has to dissolve, pass through the intestinal lining, and sometimes get metabolized by the liver first. So the graph rises slowly. For the IV drug, its level drops after the spike because the body clears it through the liver or kidneys, breaking it down or flushing it out, making the graph fall. If you want to dive into anything else or switch gears, what's on your mind?
Just don't understand why the bioavailability is the oral over the IV.
Got it. Let's make bioavailability crystal clear. Bioavailability measures how much drug reaches the bloodstream compared to a perfect delivery. IV is perfect. It's 100% because the drug
See. I see. So if a drug has an oral bioavailability of 20%, the oral dose will be 5 times larger than IV.
Exactly. You're getting it. If a drug has an oral bioavailability of 20%, it means only 20% of the oral dose reaches the bloodstream compared to IV. So you'd need an oral dose 5 times larger than the IV dose to get the same amount in the blood. Want to dig into how this applies to a specific drug or anything else?
Mm, wow. Okay. Oh God. Okay. Let's talk a bit about this first pass metabolism.
All right, let's dive into first pass metabolism. When you take a drug orally, it gets absorbed in the GI tract, mainly the stomach and intestines, and then goes straight to the liver through the portal vein. The liver, packed with enzymes like those in the cytochrome P450 system, starts breaking down the drug before it can reach the rest of the bloodstream. This process, called first pass metabolism, can significantly reduce how much active drug makes it through, which is why oral drugs often have lower bioavailability. For example, if a drug loses 80% in the liver, only 20% might hit circulation. Inhaled COPD meds, like LAMAs, mostly skip this because they target the lungs directly, but oral meds, like thofilene, get hit hard by first pass. Want to explore how this affects dosing or specific COPD drugs? What's next? First pass metabolism is what happens when you take a drug, usually by mouth, and it gets absorbed through your gut. Before it reaches the rest of your body, it goes straight to the liver through a vein called the portal vein. The liver, being the body's chemical filter, starts breaking the drug down right away, turning it into other substances, some active, some not. This means only a fraction of the original drug makes it to your bloodstream to do its job. That's why some drugs need higher doses when taken orally, or why others are better as injections to skip this liver step. Does that clear it up, or want me to
So,
dive deep?
it goes through the hepatic vein to the systemic, and I don't understand why it's called first pass. How does the name relate to the function?
Okay, let's zero in on why it's called first pass. The name comes from the drug's journey. After you swallow it, it gets absorbed in your stomach or intestines and travels through the portal vein to the liver. That's the first pass the drug makes through the liver before it even gets a chance to enter the general bloodstream, what you mentioned as the systemic circulation, which happens after the liver via the hepatic vein. The liver gets the first crack at metabolizing it, breaking down some of the drug right off the bat. So, the pass refers to that initial liver processing step, not the veins themselves. Make sense? Or is there another piece you're curious about?
So it's the first step, basically.
Yeah, exactly. It's called first pass because the liver gets the first
Okay,
shot at
quizzes on it, quizzes on it.
Ready to test your chops on first pass metabolism?
Yeah.
All right, here's a quick quiz to lock it in. 1. What organ is the main player in first pass metabolism?
The liver.
Spot on. The liver is the main player in first pass metabolism. Now, for the second question, why might a drug's dose be higher when taken orally compared to, say,
It's
an
because it's
injection?
lower bioavailability.
Nailed it. The dose is often higher orally because first pass metabolism in the liver reduces the drug's bioavailability. Less of it reaches the bloodstream. Want another question to keep the streak going? Or are you feeling good with this?
Another question from first pass for sure, dude. Another two, maybe.
Awesome. Let's keep it rolling with two more on first pass metabolism. 1. What vein carries the drug from the gut to the liver during first pass metabolism? 2. Why might some drugs be given as injections to avoid first pass metabolism?
Hepatic vein.
Actually, it's the portal vein that carries the drug from the gut to the liver during first pass metabolism, not the hepatic vein. The hepatic vein takes blood from the liver to the rest of the body after processing. Want to take a swing at the second question? Why might some drugs be given as injections to avoid first pass metabolism?
So why is it the portal vein?
Good catch. Let's clarify why it's the portal vein. When you swallow a drug, it gets absorbed through your stomach or intestines. From there, it doesn't go straight to the heart or body, it travels through the portal vein, which is like a direct pipeline to the liver. This vein is special because it collects blood from your digestive system and delivers it to the liver for that first pass metabolism we talked about, where the liver starts breaking the drug down. The hepatic vein, on the other hand, is what carries the blood out of the liver after processing, heading to the
Wait, so the
systemic.
hepatic vein is out and the portal vein is in?
Yep, you got it. The portal vein is the one bringing the drug in from the gut to the liver for that first pass metabolism. The hepatic vein is the exit route, carrying blood out of the liver to the rest of the body after the liver's done its work. Want to tackle that second question now? Why might some drugs be given as injections to avoid first pass metabolism?
I want to ask about the difference between bioavailability and bioequivalence.
All right, let's dive into bioavailability versus bioequivalence, since you're curious. Bioavailability is about how much of a drug actually gets into your bloodstream and is available to work. It's measured as a percentage, like if a drug taken orally has 50% bioavailability, only half the dose reaches systemic circulation, often because of things like first pass metabolism in the liver we talked about earlier. Bioequivalence, on the other hand, is about comparing two drugs, say a brand name drug and a generic. If they release the same amount of active ingredient into the bloodstream at the same rate, they're bioequivalent, meaning they should have the same effect. So, bioavailability is about a single drug's availability, while bioequivalence is about two drugs matching up. Clear, or want me to zoom in on anything specific?
So two drugs are bioequivalent when the bioavailability is the same eventually.
You're close. Two drugs are bioequivalent when they have the same bioavailability and they deliver the active ingredient into the bloodstream at the same rate. It's not just about reaching the same amount eventually, it's about how quickly and how much of the drug gets there, so they behave the same in your body. For example, if one drug spikes fast and the other trickles in slowly, they might have the same total bioavailability, but wouldn't be bioequivalent.
I
Because
see.
the time.
This makes sense. Okay. Well, I think we'll finish with this podcast, guys. I hope you enjoyed it. I'm gonna do a 2 months show episode now. So yeah, peace.